So moving on to Parkinson's and neurodegenerative disorders, I'm going to go through Parkinson's disease and Huntington's disease. So Parkinson's disease, this is a chronic progressive neurodegenerative disorder. It's slightly more common in males, a ratio of about 3 to 2. The prevalence is about 1 in 800 people in the UK, and is associated with age, typically over the age of 50. About 5% is familial. This is associated with mutations in the Parkin gene on chromosome 6 and the alpha-synuclein gene on chromosome 2. Risk factors include exposure to environmental toxins and family history, and smoking appears to be protective for Parkinson's disease. And Parkinson's disease is the most common cause of something known as Parkinsonism, which I'll go into more detail later on. And so the basal ganglia, the basal ganglia consist of a range of nuclei which help to control the initiation and stopping of movement. This pathway essentially starts off in the cortex, the motor cortex. So the cortical pyramidal cells release glutamate, which stimulates the striatum. And in the striatum, there are two types of dopaminergic cells. There's D1 and D2. The D1 cells contain substance P and GABA, whereas the D2 cells contain GABA and enkephalin. The substantia nigra compacta releases dopamine, which stimulates the D1 cells and inhibits the D2 cells. The D1 cells normally inhibit the globus pallidus interna and the substantia nigra reticulata. This leads to reduced inhibition of the thalamus, so disinhibition of the thalamus. Reduced or disinhibition of the thalamus allows the initiation and coordination of movements. The D2 cells inhibit the globus pallidus externa. This results in disinhibition of the subthalamic nucleus. This inhibition of the subthalamic nucleus leads to stimulation of the globus pallidus interna and substantia nuclea reticulata. This then subsequently leads to increased inhibition of the thalamus, and thus reduced movement. So a way to summarize this is D1 cells lead to more movement, D2 is less movement. In Parkinson's disease, there is a degeneration and loss of the dopaminergic cells in the substantia nigra compacta. This then, as I've described, leads to reduced stimulation of the D1 cells. This means there is less movement and less disinhibition of the thalamus. Reduced inhibition of the D2 cells then means less movement as well, as there is increased stimulation of the thalamus. And so this is a bit about the pathology. And so there is an accumulation of Lewy bodies in the substantia nigra compacta, and the loss of dopaminergic cells in these the loss of dopaminergic cells in the substantia nigra compacta due to the accumulation of Lewy bodies leads to a loss of the substantia nigra. And so this diagram shows a normal brainstem in which you can see the substantia nigra, and this is a person who has Parkinson's disease due to a loss of the substantia nigra. The degeneration of the nigrostriatal pathway leads to motor symptoms, and the depletion of dopamine in other parts of the brain, such as the hypothalamus, leads to the autonomic symptoms associated with Parkinson's disease. So the clinical manifestations of Parkinson's disease, there are 4 cardinal signs. These are tremor at rest, so resting tremor, bradykinesia, rigidity, and gait disturbance. The tremor at rest is characteristically a pill-rolling tremor at about 4 to 7 Hz, which decreases with action. It typically starts in the fingers and hands, and is usually unilateral to begin with. Bradykinesia is essentially a slowing of movements and difficulty initiating movements. Fine movements will become very slow and tremulous. The patient may have difficulty buttoning their shirt, or a difficulty with facial expression, which leads to a characteristic serpentine facies. Rigidity is excessive muscle stiffness. This tends to present with either lead pipe or cogwheel rigidity. Lead pipe is when the rigidity is constant throughout movement, whereas cogwheel rigidity is rigidity on top of tremor. And the gait disturbance is when the patient has a very slow to start walking, associated with a very rapid short stride length, and fascination with a tendency to shorten the stride length. It tends to be associated with a postural instability and increased likelihood of falling over. There are other features associated with Parkinson's, such as monotonous speech, cognitive decline, autonomic features, such as postural instability and postural hypertension. They may be very sweaty as well, may have very greasy skin, and this is all related to the autonomic features. Parkinson's in some patients is preceded by micrographia by many years, sometimes by up to 10 years, and this is when they have very small writing or progressively small writing. Differentiating features with other conditions include normal muscle power, normal reflexes, and an asymmetrical onset. And so this diagram just helps to further reiterate some of the things I've described. So tremor, unilateral one-sided tremor, which improves with action, difficulty with fine movements, a typically unilateral presentation associated with blank faces, which may progress to become bilateral. Over time, the patient may become restricted to a wheelchair, unable to move due to the severe gait disturbance. And so there's something known as the Parkinson's examination, which involves examination of the upper limb, assessment of the tremor, the face, and the gait and posture. And this is just done to differentiate between other causes of Parkinsonism and other causes of tremor. As I've mentioned, patients with Parkinson's will have a normal power, normal muscle power, normal reflexes associated with increased muscle tone. One of the ways to determine if a person has bradykinesia is to tell them to open and close their hands as fast as possible. And so a person with Parkinson's, you'll see that one side will be able to open much faster than the other. So say the left side will open very slowly, open and close very slowly, whereas the right side will open and close at a normal pace. The tremor will be an asymmetrical, so unilateral resting pill rolling tremor at about 4 to 7 hertz. And because it's a resting tremor, which tends to improve with action by distracting the patient by telling them to count down from 30, this will lead to exacerbation of the tremor. Looking at their face, you may see, say, a serpentine or blank faces. They may have difficulty with facial expressions. There's something known as the glabella tap or myosin sign. So usually, if you were to tap in between a person's eyebrows and their nose, they may initially blink but would be able to resist blinking, but in a person with Parkinson's, not unable to inhibit the blinking in response to the tapping on this region known as the glabella. You would also want to do the H test or assessment of eye movements, or really you would want to do the entire central nervous system examination in order to exclude the Parkinson's plus syndromes, which I'm going to go through later on. The patient might also have a very quiet hypertonic speech. With regards to their gait and posture, you want to observe their gait as they walk up and down the room. They'll have a very shuffling gait associated with a characteristic posture, this sort of hunched over characteristic posture, very small steps as well, difficulties turning and initiating movement, difficulty stopping as they approach walls, for example. And there's also the retropulsion test. Patients with Parkinson's will find it difficult to maintain their balance if you were to lightly push them from behind. This is something I saw in clinic. I was quite surprised. I thought it was I was surprised that the clinician was doing this. However, on going home and researching this, I found that it was a real science which is used to help diagnose Parkinson's disease. With the diagnosis of Parkinson's disease, it's diagnosed by a Parkinson's disease specialist and requires the UK Parkinson's Disease Society Brain Bank criteria. This requires the diagnosis of bradykinesia with one or more of muscular rigidity, a 4 to 6 Hz resting tremor, and postural instability, so the gait problems. It requires the exclusion of differential causes of Parkinson's, along with a supportive criteria of, say, unilateral onset, rest tremor, progressive asymmetry, and response to levodopa, amongst other features. Furthermore, neuroimaging may be performed, and I'll go into the neuroimaging in a bit more detail. And so this is an image which is just showing to help. It's just showing the brain bank clinical diagnostic criteria in more detail. You don't necessarily need to learn the entire thing. What's more important is the 4 cardinal features of Parkinson's. And so, as I've mentioned, there's something known as Parkinsonism. So Parkinsonism is a clinical syndrome consisting of the 4 key features of Parkinson's disease. However, it's important to note that it's not just Parkinson's disease which presents with these 4 key features. It may also be seen in Lewy body dementia, multi-system atrophy, progressive supranuclear palsy, and as a result of pharmacological causes. So things such as antipsychotics, MDMA, and lithium can also cause Parkinsonism. So I'm going to go into a bit more detail with regards to multi-system atrophy and progressive supranuclear palsy. So multi-system atrophy, also known as Scheidegger's disease, there are 2 forms. There's the symmetrical extrapyramidal syndrome, which is associated with overt autonomic symptoms or autonomic signs. And then there is the cerebellar syndrome with bilateral upper motor neuron signs. This tends to progress over a period of 5 to 10 years. In exam questions, the way that you're able to differentiate between this and, say, Parkinson's disease is that the patient will have symmetrical Parkinsonism with overt autonomic signs. So the question will put a particular emphasis on dysfunction of the autonomic nervous system. With progressive supranuclear palsy, this presents with extrapyramidal features and axial dystonia. There's also characteristically a supranuclear gaze palsy. The patient may have a downward eye. The downward eye movement will be impaired. So as you do the H test, the patient will find it difficult to look downwards. Over time, this will be associated with impairment of other voluntary eye movements. However, this impairment of eye movement can be overcome by doing something known as the doll's eye maneuver, or the vestibulo-ocular reflex. And so, as I've mentioned before, there are further investigations that you can do in Parkinson's disease. This includes a single photon emission computed tomography, otherwise known as SPECT. In people without Parkinson's disease, you would see this sort of pattern, a sort of common-like pattern. In abnormal or Parkinson's disease patients, you would see a dot. And so the management of Parkinson's disease, this includes the conservative management of non-motor symptoms, and management of motor symptoms. So the ongoing support and care consists of physiotherapy, so physiotherapy specific for people who have balance problems and motor function problems. Occupational therapy can include things such as installation of handrails and chairlifts inside a person's home in order to help with any mobility problems they may have. Speech and language therapy for patients who develop communication and swallowing problems as a result of their Parkinson's disease. And then the palliative care includes giving patients dignity, and so maintaining patients' dignity in conditions where they're at the end of their life. So the management of the non-motor symptoms, as given by NICE, includes modafinil for excessive daytime sleepiness. In patients with REM sleep disorder, clonazepam or melatonin may be used. In patients with nocturnal akinesia, levodopa or oral dopamine agonists may be used, along with rotagotine. Patients with orthostatic hypertension may benefit from midodrine or fludrocortisone second line. In patients with hallucinations and delusions, creatine and clozapine may be beneficial. However, it's important to note that these patients may may not be eligible for these drugs, as it may result in a worsening of their Parkinsonian symptoms, and it's absolutely contraindicated to give olanzapine. Patients who suffer from drooling may benefit from glycopyrronium bromide or a Botox injection. And patients suffering from dementia-like symptoms may benefit from cholinesterase inhibitors or memantine. And so the management of the motor symptoms includes the administration of levodopa. If symptoms do not affect the daily life, then you would give levodopa dopamine or levodopa dopamine agonists or MAOB inhibitors. However, if the symptoms do affect their daily life, then the first line is levodopa. The adjuvants include, as I've mentioned, the dopamine agonists, the MAOB inhibitors, as well as COMT inhibitors. And so examples of MAOB inhibitors include rasagiline and selegiline. COMT inhibitors includes tolcapone and entacapone. The dopamine agonists include ergot-derived and non-ergot-derived. The ergot-derived are typically not, you typically wouldn't want to give these to patients, as they are associated with pulmonary retroperitoneal and pericardial fibrotic reactions. These patients would require an echo, ESR, creatinine, and chest X-ray before treatment in order to rule out any underlying fibrotic changes. The non-ergot-derived drugs include pramipexole, ropinirole, rotigotine, and apomorphine. So a bit more with regards to the pharmacology of levodopa. So it's a precursor molecule in the metabolism of dopamine. However, if it's metabolized peripherally, it can lead to nausea and vomiting due to dopamine stimulation of the chemotactic trigger zone in the area postrema. And so in order to prevent this, peripheral aromatic acid decarboxylase inhibitors are used, such as carbidopa and penserazide, and these are usually combined in the same medication for easier dosing. There are also unwanted side effects of levodopa. This includes motor fluctuations. So there's something known as the on and off phenomena. So essentially sudden fluctuations of motor performance with periods of normal mobility, which is the on period, followed by sudden freezing, which is the off period. This occurs due to reduced response to levodopa, increased peripheral metabolism. So essentially, when a person starts levodopa, they reach the clinical effects, so they're within the clinical window quite easily, and the metabolism is somewhat slow, so there isn't rapid metabolism. As the drug is given over time, the amount of time that they spend within the clinical window is reduced, and the clinical window is it becomes narrower as well. And this occurs due to increased metabolism and reduced response to the medication. These patients may then need a larger dose of levodopa. However, increased doses of levodopa then lead to dyskinesia and dystonia. Dystonia being very intense, sustained muscle contraction, whereas dyskinesia would be uncoordinated chloroform-like movements. Furthermore, patients who are given L-dopa may suffer from neuropsychiatric problems. This includes things such as hallucinations, delirium, significant changes in their moods. There is also dopamine dysregulation syndrome, in which patients may engage in very impulsive behavior, things such as buying a lot of things, drug use, gambling, sort of hypomanic behavior. So moving on to Huntington's disease. Huntington's is a hereditary progressive neurodegenerative disease. It has an autosomal dominant inheritance with full penetrance and anticipation. It occurs due to a CAG triplet expansion of HTT, which is the Huntington protein, on chromosome 4. The disease occurs when you have a repeat number between about 36 to 35. And as I've described, there is a full penetrance and anticipation. So anticipation is when increased size of the triplet expansion leads to an earlier presentation of the disease. So here, as you can see, affected but reduced penetrance. affected, and then it starts to present earlier as the size of the expansion increases. And then full penetrance is when you have full presentation of the disease rather than partial expression. It occurs in about 5 out of 100,000 people at any age, and is the most common cause of chorea. And so the pathology, you essentially have degeneration and loss of neurons in the caudate nucleus in putamen, associated with reduced synthesis of acetylcholine. This may also lead to enlargement of the ventricles. So the canonical presentation of Huntington's disease, typically say a middle-aged person with very jerky, explosive, fidgety movements. It tends to move around to different parts of the body. It's a very sort of fidgety, sort of a puppet-like behavior, as if they're being controlled by strings. Their gait is, furthermore, tends to be very bizarre. Appears as if they have difficulty moving one side of the body. They may move the entire half of their body in order to move around because of this uncoordinated movement. It tends to be associated with neurobehavioral changes, such as forgetfulness, clumsiness. The patient may become very irritable, suspicious, or impulsive. And due to this degeneration and loss of acetylcholine, the patient may have a gradual progression of dementia, which is associated with hallucinations and impairment in their comprehension, judgment, and memory. The investigation of Huntington's disease is very similar to other neurodegenerative conditions. They should have a history and examination, along with blood tests in order to rule out differentials. However, because it's an inherited condition, genetic testing can be quite useful. This helps to determine the severity of the disease. So as I've mentioned, it occurs due to a CAG triplet expansion, and if it's less than 28, this is normal. A positive result is more than 40, and an intermediate would be about between 36 to 39. Neuroimaging can also be done. Neuroimaging would show atrophy of the caudate nucleus, as you can see here, and it may also be associated with a frontal predominant cortical atrophy. Similar to other neurodegenerative conditions, the patients will benefit from supportive treatment. This would include things such as physiotherapy, occupational therapy, chairlifts for patients who have difficulty mobilizing their home. In patients who have the cognitive decline, medication to help reduce agitation or anxiety would be useful. Genetic counseling, so in patients who may have the disease, they may recommend that their family members are tested so that they may have, say, IVF in order to give birth to the family members who may have the disease that hasn't presented yet, may then opt for IVF or genetic testing in order to prevent the disease from being passed on to their children. And also there is a drug which is known as tetrabenazine. This is typically used for other hyperkinetic movement disorders, such as Huntington's disease. So thank you for listening to this presentation. There will be a survey to fill out. This survey will help to provide you with access to these slides. So thank you for listening.